So first of all, I'll declare, I am not a physician, but I do work for the physicians, and I have one here on the stage. And I have a microphone that I'm going to give to both of them, and they get to share and play nicely with this. So first of all, thank you everyone this morning for coming out and joining us. It's very exciting to see so many faces, both here in the room and also knowing that we have so many people online virtually joining us today. I look around the room and I see a lot of familiar faces, which is great. Heard a lot of stories about the journey some of you have gone through. And before we get started and talk about who I am, human being, human doing, and introducing Michael and Sari, I want to lean out into this group to our audience and ask you, vendor, project leaders, how many of you have engaged clinicians in your project, your initiative? How many of you have done that? How about you stand up? Stand up, stand up, please. So with all of you standing up, and the Doctors of BC, we represent physicians who not only work in hospitals and healthcare facilities, we also represent physicians who work in the community. Stay standing if you as project leads and programs and initiatives have gone out to the community, to the practices where the clinicians and their patients are actually working every single day. Stay standing if that's you. Wow, what an amazing group. Let's give these guys standing a hand of applause. And it's a huge difference for those that are standing, the perspectives that you have and the things that you see every day happening within the clinics. And we're going to have Dr. Sari Cooper talk a little bit more about that and her experience as we move forward. Before I hand it over to Sari, I want to say the Doctors of BC, we're a not-for-profit society. Our physician members, their membership to our association is voluntary. So you don't have to be a member of the Doctors of BC. It costs you money to be a part of our association. What you get with that, your membership is a series of benefits that we support you, we advocate on your behalf. And that's one of the things myself and my amazing team, Joelle and Ashleen sitting over here, do every single day. Advocate for physicians and their patients, our patient partner tables over here, making sure their voices are heard every single day in the initiatives. Our team has struck up what we call clinical advisory groups. We started with 6, working with our dear partners, Mr. Tato, Shannon, and team. We had 6 small groups that then went out and engaged our 16,000 members across the province. So huge number of engagement with physicians. Those clinical advisory groups have been so successful, supporting 6 projects, where we now actually have over 22 clinical advisory groups active within BC. So a lot of projects, a lot of initiatives, a lot of things happening, but it's not all rosy. Sorry?
So Dawn, you just handed me a microphone and I'm not entirely sure what the question is, so I could actually talk for 45 minutes if you want me to.
No, I'm gonna ask you a specific question.
Okay,
First of all,
go for it.
Let's start off. Let's tell the audience who you are and what you do. You have a role as a FPSC co-chair. What does that mean?
Okay, so I'm Sari Cooper. I'm a family physician working in Victoria. I always start by telling people that I'm coming from the traditional territory of Lekwungen-speaking people, and it's a beautiful, beautiful place. Travel over here by ferry and get to look at the Gulf Islands while I'm doing that. So very privileged to live and work in that space. And I'm feeling very privileged to be here talking to this group of people because it's a bit outside my usual realm. But my usual realm has broadened quite a bit since I've been in this role. And my role is, as Dawn said, the co-chair of the FPSC, which stands for the Family Practice Services Committee, which doesn't really define what I do, because it's huge. We are a committee that is a collaboration between Doctors of BC and the Ministry of Health And my other co-chair is the ADM for primary care. And we have physician members and we have ministry members. And we have a budget that is designated within the physician master agreement to try to improve primary care. What does that mean? It spreads into whatever we think it means. And right now our biggest emphasis has been most recently on primary care networks, also the longitudinal family practice payment model and expansion thereof into other realms that family practice encompasses beyond the clinical office. Supporting physicians at the elbow in managing their practices, team-based care. I could literally go on for the entire 45 minutes talking about what we do and what the committee encompasses and what the role encompasses. I kind of laughed when I saw that Dawn was going to be asking this question because I said it took me about a year and a half to really understand when I joined the committee what it was that I had signed up for. And I've been with the committee for 4 years now, and I've been the co-chair for just over a year. And it's incredibly exciting work. There's so much opportunity in the space, and I think the digital world that you guys all exist in is a piece of it for me, but it's such a big part of my clinical work. And it is an enabler, but for the most part, it's also a burden. And so that's why I'm here, is to talk about how do we make it more of an enabler and less of a burden.
Excellent. So before we get to Michael has a really exciting title, Chief Digital Innovation Officer for the Provincial Health Services and a part of the Provincial Digital Health Strategy team. Michael, what does that mean?
That's a good question. I would say the portfolio I get to manage is really responsible for looking at areas, and the term innovation, I think, is a byproduct of the kind of the core portfolio pieces that are in my broader portfolio. So innovation in my mind is, yes, we're looking for ways to digitally innovate to help support clinicians doing things a little differently, but it's very much a kind of a thoughtful process. It's not very much just the new shiny object. It's very, I have enterprise architecture in my group. It's responsible for ensuring we have a design of the ecosystem that we're striving for. We have the strategy office. I know Shannon mentioned some of this digital strategy we have. That kind of is managed and maintained within my portfolio. And then we have I have a portfolio management office, which is really kind of to go look back at what we've been doing and how well we're doing it. And I know part of your question that you didn't ask, but we knew you talked about was, how do we engage with clinicians? And I think for my team to be remotely successful, it's all about engagement. And, we have a great partnerships around. We talk a lot. And I think that's just critical for us to be successful.
Excellent. Thanks, Michael. Which is, we talk a lot. 7 o'clock in the morning, walking the dogs is probably when we get most of the work done. And that's what we're actually going to do here today is we're going to take you on a journey that we usually have at 7 o'clock in the morning. I know Sari hates those 7 a.m. sessions, but that's truly when we really engage our physicians. So you've heard a lot about some of the innovative projects. Yesterday, there was a great panel. Dr. McCallum, Dr. Wilson talked about Prescribe It and how that journey is for them in Alberta. That's not here. That's not in BC. And I want to lean over to Sari, and she shared a story with myself and Jeff Aiken, who's the Assistant Deputy Minister. Is Jeff here this morning? So we're going to poke and prod him a little bit more on this topic about what prescribing looks like here in BC. Sorry, can you share that? Can you walk us through
what it's like to prescribe?
Yeah, what does that look like for you?
Yeah. Okay, so the first step isn't that bad. Within our EMR, we have a medication module. We can go in and put in the patient's medication. It actually is kind of clunky because you got to put in all the little different parts in the right places and make sure they're all the right numbers. And Sometimes we make a mistake, and then we click a button, and it sends it over to the pharmacy by fax. Are we still using fax? I don't really understand this. My kids are like, "What is a fax?" They're in their 20s. They're not even little. So it sends it over to by fax, which means the pharmacy gets it, I guess, as a PDF, or they print it out or something along those lines. And sometimes the fax machine is busy, it doesn't go through. But like I said, it's a complicated process to put the medication into the system, and sometimes you get the wrong dose, and sometimes you get the wrong, and then the patient shows up and says, "Oh, that's not the dose I was expecting." And then the pharmacy needs to communicate with me. Okay, so they send me a handwritten note on a PDF by fax that I receive, and it goes into the PDF section of my EMR, not the medication module. So now I have a PDF over here that has information about the patient's medication, and I have to look at it and say, "Oh, I wrote the wrong number there. They were expecting 60 and I gave them 30, or they were, lots of different ways to make tiny little errors there. And I love my pharmacy colleagues. This is not a slight on them at all. They are phenomenal. They catch little errors. This is really helpful. We work well together, but I'm getting a PDF. So then I look at the PDF and I'm like, "Oh, I got to change that." So the two ways to do that are to go into the medication module and write a new prescription, and then send that by fax. And then that's not tied to the message they sent me, so I don't know that they know that I'm responding to them. I can write a little note on the bottom saying, "As per the message that you sent me that said all of this," but that means I have to type out a whole extra piece of information. Or I can print out the PDF that they sent me, and now I have a piece of paper. We're supposed to be paperless, but I have a piece of paper. And then I handwrite, and guys, I have typical doctor handwriting. So I handwrite a note back saying, "Oops, sorry, this is what I meant. Thank you for catching that." And then I send it back to them by fax. And they have another PDF that has different information that they somehow then have to get into their system. But I not just have to print it out, I have to then hand it to my MOA, who has to scan it in and fax it. It is multiple steps to have a 2-line conversation, and none of it winds up connected to my EMR. And if I want the medication to be accurately reflected so we don't have to do the exact same thing next time, I have to then go back into the medication module and fill that out. It's an extra 10 to 15 minutes a day. That's a whole patient visit, and that might happen multiple times in a day. It is impacting my ability to provide patient care. If we had a system that could smoothly allow communication back and forth within the system, I could honestly see more patients in the day and provide more and better care. That's it.
Michael. He's like, "No, don't ask me this. Michael, how can you fix that? What can you do?" I love asking the tough questions, by the way. I have the easy job
I asked
up
not to
here.
have this, no, but it's, I'm going to step it maybe a bit back from the actual, I know we have different solutions here. I think in British Columbia, we're ahead, I would say, from a pharmaceutical system. We have a very robust system. And I think there's initially a real strong desire to work very closely with that system and make everything happen within that system. I think what's starting to change is, and I think this is part of what we're trying to push across the board, is to be pragmatic. I think the visions that we have sometimes for the systems and looking at opportunities to use other solutions that have been deployed, like that's part of what we're starting to do a lot more. What we actually changed, I think, from actually our whole approach to interoperability was what's viable, what's the experience like, and then be pragmatic. So I think what has changed for us is this ability to kind of rethink it. I think we're looking at it much more with the facts to say what, not the facts, but facts of really what are the benefits of these different solutions, and trying to remove the pride out of some of the solutions that we have. And then, I know that where we're kind of leaning towards is, let's look for what's working across the country, what's integrated within our EMRs. Those will be some of the principles that we're starting to take. So can't really get into all the details there because it's above my pay grade and somewhere else. But
Shannon, do you need to come up to the...
Shannon, Jeff are there somewhere. But it is something that we're actively working on. And actually, this is where I think my team's role is very much to support between, I would say, the business areas that are within the Ministry of Health that manage and maintain it, and then the technology. And we're looking at how do we approach these things a little differently, and then really driving home what I mentioned is the experience. Like, I think that's what we actually focus now. It's not the interoperability, the system-to-system stuff that we've always done. It's really what's the experience we're striving for, and then what is the interoperability needed to support that experience. It's a subtle shift, but I think it does help us get to better answers and better solutions.
Okay, I'm going away from my notes. Yeah, by all means.
And I just want to talk briefly about the impact that I think this actually has, that shift in talking about the experience. Physicians who have engaged with the group, with Michael and his team, are so genuinely impressed by the interest in engaging. I really want to highlight how valuable that has been, and we need to spread that out to the wider group of physicians doing the work across the province that aren't as involved, because we really need to spread that trust in the work that is happening here, that there is a genuineness to try to make the experience better. I just wanted to highlight how much I appreciate that.
And I think that is a definite shift. This isn't clinician engagement as a checkbox exercise. Okay, we've engaged the patient partners. Okay, we've engaged the physicians. This is actually truly meaningful engagement, going out into the clinics and actually watching how the clinical workflows happen. So yeah, I agree with Sari. It is a huge shift here in BC where we have that collaborative relationship to be able to do that. And that collaborative arrangement through the physician master agreement is a significant shift for us in BC. I know some of the other jurisdictions don't have that, but what we also have in BC, and Michael loves me talking about this, over 30 EMR products. And yeah, how do you connect those, Michael?
Maybe can I go off?
Yeah, you can go off. You have the mic.
I just think it ties in, and I don't know, it ties, this is about digital administrative burden. I think it was a great learning lesson for us when I got to take over this role, and we had a fantastic architecture. We had this brilliant ecosystem plan. It was great. And I used to just stare at the screen while the teams used to tell me, we're getting there. We're almost there. We're doing things. And for the life of me, I'd be like, we're not, it's like, the timelines don't work. I'm like 6-7 years out. It's not getting anywhere. And then we had this, and then we actually had the digital health strategy come in, and we had all this amazing engagement, just talking to, the rural physicians, all the different ones, hearing these things. And we started looking at what we're trying to do. And that's actually where we changed in our digital health strategy. It was interoperability was one of our strategic pillars to connected health system, because it really, at the end, is connecting, providers to providers, providers to patients, patients to their information, and patients to providers. And that's kind of been the focus. And what it did was our roadmaps changed, how we actually looked at solutions. It felt really comfortable to look across the country and say, what are other people doing that we can leverage and learn? And why are we doing things so differently here in British Columbia? What is the value? So it really, and it's funny how just that shift in perspective changed completely the way we actually architected the system and deployed it. And because Shannon mentioned yesterday, she loves delivery. It's kind of like, what timelines can we do within the next couple of years? We didn't have 8 to 9 years. And that was what we were told when we did our digital health strategy. No one was interested in a 7-year roadmap. They wanted a 3-year roadmap. And so what can we do within, right? Yeah. So,
yeah. Ray is in a rowboat here. He does not want 7 years. He wants it to happen, or else in the community, we will go and do our own thing. And then we become disconnected from the health system even more. So we have to start doing that. But you didn't answer my question about how are we connecting these 30 EMRs and the 3 instances of Cerner and 2 instances of MedTech?
That was deliberate.
I think that was deliberate.
So no, okay, it is complicated. There's no question about it. There's a lot of endpoints. That many endpoints is everything wrong. Is the biggest nightmare from an interoperability perspective. I think you've adopted principles, and we talk about them. We're going really standards-based. We're not making made in BC stuff, and that's, I think, a challenge for a lot of our teams is like, oh, here's a standard, let's make the BC version. I'm like, why? There's no need for it. Looking across the partnerships, like learning, we learn a ton talking across to our peers across the country, adopting things that are working, that works, and starting just to share those things. And then it's a deliberate approach to slowly bring things together in a thoughtful way, and engagement. Honestly, like in our connected health system project streams, like Don was saying, we have physicians, I'm gonna put in the right places. Like I don't think they really care about when we're talking about some really nerdy piece of work, but what the outcome is, they need to be there and understand it so that we can get those champions or those leaders that can help push back, and then we'll adjust. And I think what it also produces a bit of empathy between the groups. I'm a big believer in, what's the problem? We have to be empathetic to each other. You may want this, and I can only give you this, but how do we together get to a roadmap that's going to get you as close as we can and understand that we're going to get there? But I think that's how the teams talk. I think the teams are really well structured. The partnerships are really good. And so you don't have a silver bullet per se, like one tool is going to come in and do it. It's going to be lots of different tools working together. We want all our vendors to do as much work as they can together to help us be as interoperable as possible. But that's the approach we are going to take, and we're going to keep taking.
I was at an event a couple weeks back about the new refresh of the primary care network strategy with I don't know how many people are in this room, but I think it was more people than that, different partners, from health authority partners and family physician partners, divisions of family practice, nurse practitioners, all the various people that are interested and involved. And we talked about complex problems. We talked about how there isn't a single solution to a complex problem, how it's a puzzle, a jigsaw puzzle is a mess when you throw it on the floor and you start to pull the pieces together. So I just wanted to sort of give that same analogy. I think all of these issues that we're trying to work through, primary care is not one thing. It's not a problem that can be fixed with one tool. It's a complex problem that requires all the puzzle pieces coming together, and it's massive, so we need a bunch of people working together to put it together so the picture starts to form.
Sorry, actually, you can keep the microphone,
Okay.
because I want to probe a little bit more on some of your comments earlier. Yesterday, Dr. Kathleen Ross talked about she had 1,800 patients as bosses, and I work for you, the doctors of BC. I have 16,000 bosses. You guys all have your own clinical perspective, your own workflows. How do we make that work in a system of 30 EMRs? How do we get what you need out of it while still advancing as a health system?
Well, I don't actually know, because I only currently work with one EMR, and I have maybe worked with one or two others in my life, and they're quite different, and they are okay. So I'm going to explain why. One of the reasons I don't know is because I have unintentionally moved my practice 6 times in the last 8 years, because primary care has been a disaster and clinics keep shutting down, and I have to find a new place to look after my patients. And I wind up having to transition to the EMR that clinic is using, and so my data gets moved. Guess what? My data is a disaster. Shockingly, I literally have lost, the first move, I lost all the immunization data from the history in my chart. I was beside myself. I couldn't get either of the vendors to figure out the problem. They eventually lost interest and stopped responding to my emails. And I was persistent. I called our CMPA, it's our Medical Protective Association, because I am actually required to keep that data. I have a covenant, a license that requires me to keep that data for 16 years after it's been entered into the system, but it's just gone. Every time I have moved, I've lost data, and when I haven't lost it, it comes in PDF labeled as transfer. Thousands of documents labeled as transfer PDF. I don't know how to fix that. I just left it because I can't. And in a situation where a patient comes in with a challenging problem and I need something from their history, I'm just going back, clicking through PDFs. I don't know how to fix that. I think that I don't know. That's why I look to you guys. You talked about, Michael mentioned the words a group of nerdy people. I've always considered myself kind of a nerdy person, but I'm so excited to be in a room full of people that I think are probably nerdier than me. That's awesome.
So Michael,
Yep.
how can you help, with those types of data transfer, data portability?
These were on the list, Dawn.
These weren't on the list, but we still ask, right?
So I think data portability. I think there's a couple things. I know we should be a little more prescriptive when it comes to a standard, and I think that's what we are working on. I think then we need to recognize there's a cost to extracting data, and look for how clear, what are right fees for those type of things. But then I think it's us, especially in the Canada Health leadership, to kind of propose and get this standard done so that we can then help extract this scenario, because this isn't unique. And right now it is just a straight transfer from, you got to get someone to come in there to transfer from one EMR to another and do all the mapping. And I'd pay for it. Yeah. Yeah, no, but I think this is where a clear standard that we all adopt and agree to, and then the policies to come into that. I think that would be the next piece, would be really, how do you support, how do we expect all of us to play in this kind of data portability? But right now it's not as thoughtful as we could have.
Yeah, and I know some of the other jurisdictions here, you have health-specific legislation. BC is one of those jurisdictions that does not. We have the Freedom of Information Protection and Privacy Act in the health authorities, HIPAA in the Community Personal Information Protection Act, and they're designed not to share information. So when you're talking about interoperability in that ecosystem, it doesn't work from a legislative framework. We have an election next year. Is this one of the top topics? No, it's not. But access to primary care is a foundational issue. SARI needs more time to be able to deal with patients. So, sorry, what type of solution would help reduce those administrative burdens? What type of app would be your dream app?
I just want to be able to talk to people. I just want to be able to asynchronously, so that I don't have to find a time between patients to get on the phone and have a conversation with somebody when they're busy and I'm interrupting them. I don't want to do that. I'm a people pleaser. I don't like interrupting people. That's very uncomfortable. But And when somebody calls me and we need to talk, I have to step out of a room, and that interrupts a patient encounter, or it interrupts a train of thought, and man, it's really hard to get back to that. I think that asynchronous communication that is integrated in the right part of my patient's file, it just makes sense. And I don't know why we can't do that. I don't understand why we can't make the systems talk to each other so that the information is where I need it to be, so that I can look it up quickly, so that I'm not wasting time clicking on things and finding the wrong, oh, that wasn't the right one, that wasn't the right button. I need to know what's going on with my patients so that I can help them. This is about patient care. It's not about it. It's about reducing administrative burden, so people want to do this work. It shouldn't be hard. It should be enabling. I remember the first time I transitioned from paper. I used to work on paper. I miss it. honestly, it was so easy. You just write the chart and you're done. And yeah, it was a pain in the butt to look through things, but it didn't involve thousands and thousands of clicks. It was actually, like, to say that it was easier to work on paper than it is to work in an electronic system. And I've been doing that for probably 15 years now, and it's not gotten easier.
You still have to fax to the hospital.
And I still have to fax to the hospital and the pharmacy and other doctors' offices.
Yeah.
You can't even communicate across the community.
So you want your dream app as a connected app.
Connected communication.
So Michael, leaning over to you. How are you going to fix it? No, just
Yeah. No, I think there are some things that we are doing right now that will address some of that burden. I think it was actually one of the big shifts for us was to go to an RFP for our digital referrals and orders. We had spent a long time building our own, and that was one of the first things that scared me when I'm looking at it. I'm like, man, we're never getting anywhere here. And so we decided to purchase a solution, so that, at least provides us a pathway for that. I think also with the information, I think one of the kind of parts of our core architecture around the connected health system is there was actually a great diagram yesterday with all the data getting thrown around all over the place. It really is, I'm a big believer in the smart middle, and so I really want us to be really thoughtful of our provincial data sets and where they're useful, and then have them not be really hard to get to. So that's one of the commitments we're working on, is a very clear set of provincial APIs for vendors to connect to. Like, that is literally our goal with fast. We have to deliver that fast. So that type of rich provincial data is there to help augment, right? So the labs should flow much easier than coming in as PDFs. So I think we have some specific plans literally to reduce the burden, to make it easier to find. We obviously have to partner with our vendor partners to get there, but what we want to do and want to commit to is making that connection easier. Like, I have a kind of a developer background, and there was nothing as great as seeing a big, massive conformance document and really esoteric specs to do something. We want to make it as simple as possible, so that you want to take that, you want to have that information in there, so that she gets the most relevant information into her system as well, and then connect those referrals and those patterns. And we're not talking about also the patient. And part of what, and maybe I'm overusing this experience, what we're actually doing from a patient perspective is doing exactly what we did with providers. Look at the patient experience, not just in little areas. Oh, I've got a great little portal here, I've got this. We want to go across the board. So when you're a patient that you just need to see your information, it's the same place you're going to go if you're a cancer patient, you want to get the screening. We want to have that consistency. If we have to hop you out, we want to help really be your concierge to get that. So we want that experience to be as strong as possible. And that, and just once again, is absolutely changing the architectures and the designs of the systems that we're building. And we want to create that asynchronous communication in this solution to kind of flow back into the providers as well. So it is definitely there, but it's all, for us, it's kind of more of an experience team, the more I say it, than an architect. But it is really driving that, because that's what we find helps, get rid of that administrative burden.
Thank you. And yeah, I should have also mentioned not just communicating with other physicians, pharmacies, hospitals, and all of that, but communicating with the patients. We don't have. I work in a clinic that is owned and run by the health authority, but functions in the community. And because of the privacy legislation, we haven't been able to push the button to use the portal that is connected to the EMR. And what that means is I can't talk to my patients without making a phone call. I can't have a back and forth or even a one-way conversation to send them information that they need, because that's against privacy legislation. And when privacy legislation is impacting patient care, that's a huge problem. Patient care is the fundamental, like, that's my job. That's what I'm supposed to be doing, caring for patients. But these rules are getting in the way. And to me, the risk of that is way higher than the risk of the information getting intercepted. I don't want that to happen either. It's important, but we should be able to do both easily.
And that legislation, I think, that affects the health authorities is freedom of information and protection of privacy. There has to be a balance that ensuring an individual has a right of access to their records. So Michael, we haven't talked about this yet, patient access. What's happening within the BC landscape for patients getting access?
So we have already in BC, we already have a what we call a health gateway, and it would be, I would call it, there was a term yesterday, cylinder of excellence. So it's a nice tool that's got a lot of your longitudinal data. What we are looking though is how do you expand it into being part of, we have a big cancer plan. Like how do we have it so it's part of the screening programs? Really taking patient experience around not just your data, but your flow within the complexity of the health system. So how as you as a patient tracking yourself around it? So we have a big unattached, we have an unattached patient problem in British Columbia, and if it's not. I think we can attach people not just to providers and to services, but to their data and to where they are in the individual workflow. In an ideal world, you call our 811 nurse line. That information flows back in. You're aware of it. You get to go to a virtual physician. That information flows to that physician. They see it. You also then go to a walk-in clinic. That information is with you. You don't need to retell your story. You're not isolating yourself. When we send a referral, if you send a referral to a specialist, you should be able to. And this is the part, this is what we're working on because it makes common sense. It's like, you send a referral, I should know where the referral's at too. Right? And who's calling me and where it is and that status and those messages. So those are all the things that we're kind of working flow that kind of from an experience perspective and looking for opportunities over time, because we want to be pragmatic in what we can deliver, is the more and more experiences we can pull into this kind of common experience platform. And I'm using that not in that there's a platform per se, more in just the general sense, is that we want to have that there so there's less and less impact. Or need for patients to kind of meander around.
When you say platform, you don't mean another portal, though.
No, well, it will end up being something to that effect, but but
another
it'll be
username and login for you. Sorry.
No. Okay, we should talk about identity. That's a whole other conversation. But yeah, but those are things we have to look at. What is the identity? How do we manage identity when we're distributing data all over the place? Logging into the EMR with your little login password. How do you then safely connect into those provincial data systems? So this is where I would say empathy comes in. We got to work with the physician, say, we need you to do this amount so we can give you this amount. So there's at least value in what we're providing.
And in order to get the physicians or clinicians to agree to that trust has to exist. And that's what is happening over the last, I would say, year and a half, 2 years, that bridge is being built. And it's a slow process because we have 6,000 family physicians, I think, in the province, or 6,000 to 7,000. Only about 3,000 are providing longitudinal care, which tells you something about the state of trying to provide longitudinal care in the province. These people trained as family physicians, and half of them don't want to do the work. That's my job at FPSC. That's my job, is to try to make it better so that more people want to do it. And in order to do that, we need these partnerships, and they need to be built on trust, because there's a lot of distrust in the space right now. And these Michael and his team and all the other people that I've met through this partnership they're trying. They're doing really good work to build those bridges.
And I actually have to say the experience in BC that we've had over the past year and a half, starting with the Digital Referrals and Orders project, and Shannon mentioned a bit of this yesterday, going out to RFP. She mentioned about 70 clinicians. This is the first time in my time in the province of BC where community providers, those that have no relationship with the health authority, were invited to participate, evaluate, and see the demonstrations of the products themselves that they were going to be using every day. And some people think, well, that's nonsense. Well, that's a no-brainer. But it's the first time in the province of BC. So hats off to you, Shannon, and to you, Michael, for enabling that to happen. It is a huge change.
And can I say that you needed trust there? Because when I saw the list, I was like, well, this is going to be interesting to see if we can execute on it, because there were so many people involved. But it was great. Like it was sufficient. And at the end, you could actually trust what we got, because it was not us deciding it. Like we had just a little bit, there were some core elements that we wanted to nail to make sure they were there, but everything else was just what the physicians felt was the best.
And actually, seeing how it's now being implemented, this is clinician-driven. You have clinicians on the front line that are a part of the development work. We have over here Dr. Brinder Narang that sits and co-chairs with the Digital Referrals and Order Steering Committee. He's a co-chair of the committee. It is being led by physicians. So a huge change. They have a patient partner group that's working in. We have clinical advisory groups, so a huge shift. And that's only been in the last year and a half. So we've been doing it for a long time, just a different way. So a shift in BC, which is a positive change. We have about 5 minutes left. We've touched on a few things. You've heard Sari's journey. You've heard some of Michael's trying to script my tough questions, but pulling it back in and actually answering. Do you guys have any questions for them? Yes, Verinder, of course you can ask.
Oh boy. Nice.
I'll preface it by saying I trust you, Mike. And Shannon, I trust you. So one's more of a reflection and a comment, and one's an actual question, I think, more for people in the room as well. The comment comes from the presentation on Prescribe It yesterday, where, how does it make you feel up there to know that there's a London Drugs in downtown Vancouver that is enabled with Prescribe It, but can only receive prescriptions electronically from providers outside of the province? To me, that feels pretty crappy. So that's just a question for us to think about. But the actual question goes back to the legislation and the EMR question. So I know one of the limitations on the data portability, the costs and all that is, because of legislation issues in BC and that it's not legislated. But how much of the onus is on government and how much of the onus is on vendors? Because they're the same vendors that are working in jurisdictions that have legislation that are, working here. But there's different rules of engagement.
So I was on a panel at a conference January? Was that this past February? I don't remember what conference it was, but I think it was maybe I see familiar faces, so maybe a number of you were there, and you would have heard me say this, because one of the questions that we were asked was, what would you have to say to the people in the room? And I took that opportunity, and I'm going to take it again, is to say to the vendors in the room that yeah, you guys are private businesses, and the bottom line is important. Some of you probably have shareholders and things like that you have to be responsible and accountable to. But you've stepped into a healthcare space. And in order to, I would challenge you all to think about, as a physician, I earn a living through this work, but my goal is to provide really good care to my patients. And if you step into a healthcare space, that needs to at least be somewhere in your goal, in your mandate. And part of that is enabling the people trying to do the work better.
Hi, my name is Wayne Samuels from Medicenters Canada. We have a number of clinics and we serve doctors in Alberta to provide primary care. I'm actually going to ask the opposite question, which is what can other jurisdictions learn from what you've done in BC? You talked about trust, and you talked about it obliquely. Nobody likes to talk about it, but at the heart of that, a lot of that, it comes down to the money, right? So BC, I know it's been, you referenced it, Sarah, it's been a long time coming. It's been really challenging for clinics to keep their doors open, and BC finally announced a new model, which is now a giant sucking sound for the rest of Canada, because primary care docs are leaving, our provinces and going to BC. So that was the first step, and I think something that caused a lot of issues that still exist in other places around trust. But it also costs money to do the clinician engagement you talked about, to build that trust. So obviously there's a commitment behind this from the government, from the PHSA, from others to say, we're going to spend what it takes to engage the physicians, engage the patients. We're going to fix the basic financial issues first, which needs to be solved. How do you get the governments to understand the importance of that and see the value of it with all the competing priorities about money and be able to say, we are going to fund what it takes to actually get this done? Because this is, at the end of the day, is it purely political? Is there a cost benefit? Is there an ROI? What did you use, as part of the government or part of the health authorities, as Doctors BC, when you spoke to the government to say, yeah, unfortunately this costs money, but this is what's the outcome going to be, and how do you cross that barrier?
I think that it's difficult to describe the value of the collaborative committees that we have set up in the province. The Family Practice Services Committee is one of them. We also have a Specialist Services Committee. We have a Joint Standing Committee on Rural Care, which is both primary care and specialist services in rural areas. And then we have a Shared Care Committee. And each of those committees is led by a partnership of a physician and a ministry partner who are high-level people within government. And we have the ear and have had the opportunity. We don't advocate in those spaces broadly. We don't go out to the news and yell at the government for not doing what they need to do. We talk to them. We build relationships. We've talked to, I talked to my partner, my co-chair, who is the ADM for primary care, about what primary care is and what doctors feel. It becomes about, like, I can't provide care for my patients, and that actually physically hurts me. And they start to hear and understand, we're not asking for money because we want wealth. We're asking for money because we want to build the system back. We can't continue to lose doctors to Alberta. We had the flow was going the other way. What I've heard is some people who moved to Alberta to set up a practice because it was so much better there are coming back. So, it is, and what has happened since that new payment model was announced is we've had other medical associations calling Doctors of BC to say, how did you guys do that? And the answer has generally been the opportunity to build relationships between physicians and government that's not adversarial, but based on true understanding. And conversation that I often wind up initiating is, what do you guys need? How can I help you with your needs? And then it reverses the flow. They start to understand. We can say, look, you guys are under immense pressure. We get that. How can we help you? How can we come to something that is going to work well for all of us, rather than we need. It is a much better way of working when we are working together. It's not to say nobody goes to the newspapers. People do. We don't. we have a relationship to maintain and build and nurture.
I'll build off of our point. The Doctors of BC is an association. Some of our membership dues go towards physician participation in digital health. So we pay for the physicians to be at the table and to make sure that their clinical time that they're missing is compensated. That is our members' due. That is important for our association to make sure, and our members have said that's a priority. We want to be at the table.
Yeah, incredibly. Thank you.
Excellent. Sorry, go ahead.
Hi, I'm Glenn Geiger from Ottawa. So I'm going to break this comment into two parts. I'll try to be quick. Dr. Shaw, I believe it was Dr. Shaw yesterday, talked about having seen the future was in California. I'm here from the future, right? And where I practice, in our integration, our technology platforms, it's fantastic. Dealing with care using electronic tools is fantastic. And I've been in practice for decades. And this is the most fun, the most beneficial, the most powerful implementation of functionality. It's really, really helpful. So part of the message is it can be done. And that's what I think sometimes people forget, right? But hidden in that is some problems in the conversation we're having today. So I first want to pick up on digital administrative burden, which was the topic we're supposed to be talking about. Dr. Cooper, you gave some really excellent examples about your faxing and everything else. When I talk to people about this, their problem is they're using their EMRs as glorified typewriters, which was the scenario you described. The only way out of that is to move forward, which is kind of what we're talking about. Moving forward is going to require change. And in the dialogue I have with physicians, they have the problems, but when you say, well, let's do this, oh no, we can't do that. I go, you're going to have to do that. And so part of the engagement conversation is a two-way aspect. It's nice that the government listens to us, but at the same time, the physician community needs to listen as well and be open to change. And that's the challenge I see in your portfolio and the challenge people have. The only way out of it, it's not a digital administrative burden problem. It's an administrative burden problem, and the technology has not been set up to work effectively. In my world, it's fantastic when you get it right.
That gives me hope.
There you go. So the second part is directed at Michael here is, no offense, your strategy sounds like we could be having this conversation for years to come. But so let me just suggest this, is it's not about data. It's about connectivity. To help her, it's about connecting. So a lot of our conversation, standards, blah, 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 shut up. And you just had the right idea. We'll take that standard. Let's move the conversation forward, because the thing to do is to use technology platforms to create workflows, not data. Yeah, you need data, I'm not suggesting otherwise, but you need unifying workflows that allow, the fax example is a perfect example of the problem. You give it, it's a poster of what's wrong. If you can't fix that, I thought, yes, it's a data problem, but it's a workflow problem. So I want to suggest that that's what you have to focus on.
Thank you.
Yeah, I'll be reasonably quick, I think. Okay. More than 10 years ago, because you're talking about the data mobility problem as you're moving clinics. More than 10 years ago, I worked on a project funded by the Doctors of BC about a data transfer standard between EMRs. And other provinces have done similar work. So the barrier, I don't think, is data and standards. There's got to be a business and policy barrier someplace. So what do you think those business and policy barriers are?
I think there's a carrot and a stick. So I'll answer really quickly because I know we're well past time. The carrot incentivizing both the provider and the vendors, and the stick, the legislation, the regulation, the regulatory framework around it. And right now in BC, we're moving towards the carrot. We don't quite have the stick yet, but I think it's a multi-pronged approach. Okay, we are well past our time. Thank you, Sheena. Thank you, everyone.